So it's the end of the afternoon. You are all very tired, and so now we are not going to make some science or talking about muscles, nerves, and that stuff. I just wanted to share with you this project and maybe trying to find with you some links between neuro-orthopedics project and the parasport. As you may know, we are going to have the Paralympic Games in 2024. And for that, we have a huge project here in France for the development of a special institute. And in this way, our team thought that maybe we have to create strong link between neuro-orthopedics and parasport for our passion. As everyone knows here, life expectancy for people with disability is increasing, and it's largely increasing, and that's a good news. And also a good news that the quality of life is increasing also, and people with disabilities are now actors and decision makers. And when we have this kind of passion during consultation, they want always more and to live as everyone lives. So they want to be a population like any other. As you know, it was a little bit the start point of my discussion. That everyone knows here that disability is an universal dimension. And injuries, we all experience disability situations. Disability is situational. Disability situation is not permanent. It depends on the life situation. I've made an example here. A mute lawyer is more handicapped to plead than alone on a deserted island during his vacation. And disability is singular. And I think we have to let's stop considering that the disabled population is a single homogeneous group in the same way as the general population. And it's a sum of particular cases. It's not only sensorial, psychological, motor, or that stuff. Inside each group, we have a lot of particular cases, and us in neuro-orthopedics, we know that. For the follow-up of sport and activity physique for people with disability, there is no recommendation. As you may know also, medicine is also about prevention. And when we consider patient with or people with disability, we always think in primary, the primary thinking is about secondary prevention, how to recover through sport, how to gain autonomy, how to ensure a specialized follow-up. Sometimes we think about tertiary prevention, how to avoid recurrence of the disease that's caused the disability. But now, with the increasing of the expectancy of life of this population, we have to think about the primary prevention is how to avoid the appearance of disease. And I think it's a real public health issue in our country because we are not organized until now how to follow this population for the primary prevention. And everyone knows here that physical activity and sport is one of the main points of the primary prevention. And maybe our discipline and physical medicine and rehabilitation, and maybe all the discipline involved in the neuro-orthopedics may have a chance to take the lead about this primary prevention and how to organize it. And I'm trying to explain how is my feeling about that. If life expectancy increases with aspiration to quality of life identical to the general population, we must ask ourselves the question of aging well for the population with disability and think about the risk of over-disability, which identifies a major factor for this population. Indeed, physical activity and sport is a way to reduce comorbidities, like in the general population, to reduce obesity, sedentary lifestyle, hypertension, diabetes. And it's quite often now that we can see all paraplegic with diabetes, who are overweight, and sometimes who had made a heart attack or a stroke. But parasports may induce over-disability. For example, a paratennisman who deteriorates his shoulder at the age of 35 while practicing his sport may lose his autonomy at the age of 60. It was not an issue 30 years ago, but now it's a real issue because this sportsman will need some specific assistance for his transfer, maybe more caregivers, and obviously an additional cost for the society. So, unlike the general population, we think that these two factors seem to have the same weight for this kind of population, and there's a lot of contradiction maybe that we have to work on. So, a telephone survey conducted a few years ago revealed that there's 3 reasons why a patient with a motor disability who has been out of our PRM department for more than 2 years, does not practice parasport were, first of all, the fact that they do not like sport. It's not because you are a paraplegic, it's that you like sport. Secondly, the fact that the world of health is a hindrance, and we are going to see why. And third, the territorial network. So with this study, we think why we wanted to try to find why the world of health is an obstacle for the practice of parasport. In fact, the medical office is the gateway to the practice of physical activity and sport, giving the certificate of aptitude, practice reserve, modality of practice, technical aids, etc. And these elements are not taught in the generalist medical and paramedical training in our country, and these people are a little bit lost when they want to practice some activity, physical activity and sport. And secondly, we need to write recommendations for follow-up because of the injuries that the sport can provoke. And so also there is another issue that, and we live that nowadays, is that the world of sport underestimates the health dimension for this kind of population. We have here Didier Pradon, which is our biomedical engineer who is working with us on this topic, say that the world of sport is the main objective, the main goal is the prophylaxis of the underperformance. And this is really, really important. We are not here, the health professional, to take place of the sports professional, but we need to be close to these people. As a support to help people with DLP practice more and better, to understand this need for a permanent and regular follow-up with this population, obviously for the causal pathology, but also for the after effects and for the practice of physical activity and or sport. And the real question we have here in France, preparing, the Olympic and Paralympic Games, is that a person with a disability playing sport, or is it a sportsman with a disability? And it changes a lot of things. So now why we can think that, neuro-orthopedics and physical activity sport are not exactly on the same pathway, but they are going maybe to cross in one day. It's because we think that, and as we are all, unfortunately, all experienced with the pandemic, we know that in order to practice some physical activity and sport, we must first get out of our house. That's very difficult to practice sport when you stay at home. And one of the main goals of neuro-orthopedics is to give some people the ability to go outside, to walk and to practice outside. So this may be in the field of neuro-orthopedics. Secondly, the practice of physical activity or sports requires the improvement of functional capacities to go outside, but also to use devices for mobility and sport practice. And this also may be in the field of neuro-orthopedics, using all these devices for mobility, wheelchair, the sports device, but also, why not, botulinum toxin, all the treatment we have discussed today. For the neuromotor patient, this improvement is achieved through a neuro-orthopedic medical, surgical, and proactive approach. We are here in our department at Garches, and you are going to see, when we are going to see a film for an example, we can, with our organization, take care of these patients who want to practice physical activity and sport until the athletes of the national team. You can see there is obviously orthotics, prosthetic, shoes, surgery, botulinum toxin, assessment in a gait laboratory, etc., etc. So this is also inside the field of neuroorthopedics. Here you can see I was in Tokyo with Frédéric, who is over there, and I have you can see it's a paraplegic athlete from French team, and he's practicing long distance shooting rifle. I don't know how to say that, and he has some spasm on his left leg, and while he's training, I tried to find which muscle was, doing like this, and it was really funny to be here and waiting while he's shooting, and sorry, I'm lost. So after that, we go outside. You see that I bought your device, Paul, because it's a Lumify, a way to practice some sonography very, very easily. And I practice a lidocaine injection in the muscle just to during the competition to avoid this spasm of the quadriceps. So this is a little example, but what is really important is now this. So I'm going to present to you very, very quickly the project, which is in the Institut de Santé Parasport Connecté, which can be translated Connected Parasport Health Institute. Don't worry, the name is going to change. It's a project which aims is to build on a site close to Paris, in Yvelines, France, the first institute in the world dedicated exclusively to parasports health and to be inaugurated during the Paralympic Games of 2024. It benefits from the Heritage Label of 2024 Olympics, signaling an ambition to participate in the development of population in a sustainable way, even after the Paralympic Games. It will bring together the expertise and infrastructure necessary to support people with disabilities in the practice of physical activity and sport at all levels. The health operator is Assistance Publique Hôpitaux de Paris, but we are discussing to add another, health operator. There are 3 until now, waiting for our approval. And the university with the research and teaching operator is Paris-Saclay, Université Paris-Saclay, and the major public financial for the investment is our department. So the SPC will mobilize an ecosystem of medical, scientific, educational and technological skill on a single site dedicated to the assessment of adapted recreational sport, parasport health, detection and then support of his high potential athlete, as well as the training of dedicated health professionals, research into improving the performance of disabled athletes and their equipment. The objective of this institute are becoming the first national center of reference for prevention through physical activity and sport for people with disabilities, making the practice of an adapted physical activity medically and technically possible for a target of more than 10,000 consultations per year, training 250 professionals in the parasportive capacity assessment, whether they are health, rehabilitation or sports professionals, initiating and centralizing excellent physiological and technological research around parasports by bringing together skill and public as well as private resources. There will be there a lot of sports infrastructure which are all connected. It will be really a living lab of sports. and a way where we can assess the mobility of people with disability, whatever the way in real life. Assessing the services expected from innovative medical disability compensation devices, establishing a database of good parasport practice and technological innovation in this area, positioning itself as a center of reference for the classification of parasport athletes for national and international competition, and becoming the National Medico-Technical and Medico-Administrative Assessment Center for the management of technical equipment, orthopedic device, and assistance for sport and leisure. This institute has a unique ambition in sports and health for people with disabilities as a driver of innovation, creativity, and dynamism. It therefore aims to enable people with disability to improve their mobility, physical activity, wellness, leisure sport, competitive, and high-level sport. Next, not the next, but the next of the next snob will be there, I think. So, the implementation of this objective requires several innovations, some of which have already been developed within the so-called test tube model. This is a prefiguring branch of the ESPC present on the site of our hospital nowadays. It's open. We have 150 square meter over there with high-level technology. It's in our hospital, and it develops the three pillars of the project: health, training, and research. So this department is not a sport practicing area, it's not an hospital, it's between, with strong connection for diagnosis, assessment, material adaptation, education, prevention, stage follow-up, and advices. So it's not an hospital, a place of care. It's a place of consultation, advice, follow-up at the service of health. It's not for all audiences, it's for people with disabilities. It's not dedicated only to seniors and dependency, dedicated to the practice of physical and sporting activities throughout life. It's not a place of practice, it's a place of empowerment, first and secondary prevention, etc. It's not a rehabilitation center, it's a place of expertise and excellence in sports and health, which works for the benefits of all. And it's not the combination of an hospital and a university, it's a real multidisciplinary ecosystem. And it's not a regional, Ile-de-France system. Now we can say to you that it's a national spin-off project. So where it will take place? It will take place in a site which is close Les Mureaux, which is Becheville. It's a little bit at the north of Paris, but in our department here, Les Yvelines. It's inside, a forest. It's over there. And it's a place where we will have a new train which is going from Paris in 18 minutes and arriving directly in the center. Obviously, it's a lot of money. The investment is about 40 million euros. We have already 20. We have already the money to be sure that we can make, the follow-up for the construction of the project until 2024. And after that, we need 5 million euros for the equipment of all the infrastructure. So it's obviously we had to build a scaling up over 4 stages until 2030, which is the target model. So we are going to be there in 2024, and after we need to transfer, install, upscaling, and to reach our target model in 2030. It will be about, at the end, a full-time staff about 90 person and financial cost per year at about 6 million euros. So this is a real big and strong project. We have a lot of collaborations. And as you can see, there is a Comité Paralympic, the university, the ministry, that all these people. There is some private company. We need a lot of private company because we need a lot of money. And so I think maybe this project is going by itself, growing in his way. Maybe we have to think how to make some link between, you know, the mobility, how to improve the mobility of patients, and how after, what are they going to do when a patient can't stand, and after he stands, he wants to walk, but when he walks, he wants to run, and when he runs. And so we need to have all the environment to be with them and to help them to take care of their health. So that's it. I have finished for this presentation, and now I would like to present Dr. Constance Pétier-Melon, who is the doctor of the test tube model. And she is going to present to you one example of a patient. Tu te branches là-dessus. Ah. Ça. Alors je te redonnerai pour le film, c'est ça? Laissez-le parce que pour le film, il est là après. C'est moi, le film, il est sur celui-là. So, Constance.
Thank you. Hello, everyone. I would like to present to you the multidisciplinary and specialist care of 42 years old golfer by our ESPC team. Julien is a 42 years old man, part of the French Paragolf team. He was diagnosed with a pelvic osteosarcoma in 1997. He underwent chemotherapy, radiotherapy, and pelvic surgery with left iliac wing resection and hip reconstruction at the time, and was considered cured. Julien is eligible for Paragolf competition as he has a limitation in gait and swing due to muscle weakness, active hip amplitude deficit, and the significant difference in lower limb length. On clinical examination, we objectified a 6.5 centimeter difference in the length of the lower limbs. Examination also revealed an absence of hip active flexion as well as a weakness of abduction hip. Julien presented with growing chronic pain and an increasing restriction in his daily walking and a major impairment of his golf practice. An MRI was prescribed to eliminate a relapsing tumor process and objectifying stage 4 hip osteoarthritis. Patients' expectation concerned mainly pain relief, recovery of walking distance, and the possibility to resume playing golf. Due to the complexity of the case, a multidisciplinary discussion was required. The sport medicine consultation of Garth Hospital Paul Parasport is organized by the ESPC Institute. We offer a multidisciplinary approach to complex cases of disabled athletes struggling to resume sport. Concerning Julien, the discussion involved physician, surgeon, adapted physical activity trainer, orthesist, and specialist sport coach. Julien was offered a course of care starting with a precise assessment of his pain in order to validate the surgical project. At the same time, medication and equipment were prescribed to quickly relieve pain and to do physical preparation for surgery. Following surgery, a hospitalization in a rehabilitation center for special postoperative care with close monitoring was programmed, as well as a well-conducted rehabilitation for resumption of golf. The first step was to complete the assessment to validate the surgery. The treatment of pain include pain-killing medication, but also a pair of orthopedic shoes compensating the inequality of lower limbs, length of and muscle strengthening. The assessment validates the indication for total hip arthroplasty. Prior to surgery, a personalized training program was offered by our adapted physical activity trainer in conjunction with his physiotherapist. Support from a dietitian resulted in weight loss. Julien was operated on by Dr. Calais and Professor Genet at Raymond's Poincaré Hospital in Garches. And they will come back to the technique in a short movie after this presentation. Following discharge from surgery, our patient was hospitalized in the Goussonville Rehabilitation Center. The first step of postoperative re-education consists only of slight mobilization of the lower limb due to a contraindication of any pressure on the left lower limb for 45 days. Julien gradually recovered the pressure on his lower left limb and strengthened his muscle. We saw Julien again 60 days after the operation, and he was walking painlessly and without any assistance. The difference of length between his limb was reduced to 2.5 centimeters only. He had recovered his muscle level. We did not find any notion of contraindication to the resumption of golf after total hip prosthesis in the literature, but only in case of classic care. Julien should be accompanied during his recovery in a safe manner in order to limit the risk of prosthesis dislocation. For this, we will continue a progressive muscle strengthening program in a swing movement in conjunction with his trainer. For the sporting recovery, we are planning a pair of golf shoes with studs to lower the risk of falling on the course. It was compression short with proprioceptive reminder to limit the maximum amplitude of internal and external hip rotation will be made to measure. This short will allow Julien to better endure his golf course since he suffered preoperatively from an organ displacement. The resumption on practice and course will be gentle and progressive under the supervision of his trainer, who will have warned of the movement to be limited as first. We expect a return to competition within 4 or 5 months. Thank you.
So, time just to make a quick change. So, as you see, it's for a competitor. It's not for a first sportsman. I want just to show you this quick movie of this story.
Bonjour, je suis Julien Mouchet, d'Aix, dans le sud-ouest de la France. Et je joue au golf au club de seniors.
Sorry.
En 1997, on m'a découvert une tumeur sur la gauche. Pour me soigner, j'ai eu un traitement de chimiothérapie et de radiothérapie, et également une opération au niveau de ma hanche gauche. Depuis l'opération, j'ai une déficience physique au niveau de la jambe gauche. Suite à cette opération, les certains sports n'étaient plus possibles pour moi. J'ai persévéré, j'ai continué à jouer au golf, et depuis quelques années, j'ai intégré le groupe de l'équipe de France de Paragolf. J'ai connu l'ISPC grâce à Constance Petit, qui est la docteure de l'équipe de France Paragolf. Donc Constance m'a proposé de venir en consultation à l'ISPC, ce que j'ai tout de suite accepté, puisque moi-même, j'étais dans une réflexion de prendre soin de moi, puisqu'en fait, les douleurs au niveau de ma jambe devenaient insupportables au quotidien, et également dans la pratique sportive.
Bonjour, je suis le docteur Constance Salmon-Petit, je suis médecin en médecine physique et de réadaptation et médecin du sport, et j'ai rejoint en septembre 2021. Donc je suis Julien Mouchet, puisqu'il est membre de l'équipe de France Paragolf et je suis le médecin en charge de leur suivi. Et donc après une compétition, il m'a fait part de ses douleurs de hanche. Je me suis dit que toute seule sur une compétition, ça allait être compliqué de lui proposer une solution. Donc je lui ai parlé de l'ISPC afin qu'on puisse discuter de façon pluridisciplinaire autour de son cas pour lui proposer les solutions les plus adaptées. Et donc grâce à l'ISPC, à cette consultation pluridisciplinaire, on a pu prendre l'avis d'un chirurgien très spécialisé dans la hanche, qui est le professeur Genet, qui a pu donner son avis et donc on a pu réfléchir à une chirurgie très spécifique sur un cas complexe.
Stressé, oui, un petit peu, parce que c'est plutôt un stress positif par rapport à... C'est-à-dire que je suis conscient de ce qui va arriver, de ce qui va arriver avec les docteurs. Voilà, si je n'étais pas un minimum, c'est-à-dire que je serais inconscient de ce qui va arriver. Donc plutôt hâte, serein, un stress positif, et voilà, j'ai hâte à demain matin de revoir les docteurs et qu'ils puissent apporter du bien-être pour la suite.
Donc Fabien Calais, chirurgien orthopédiste à Garches. Alors c'était François Genet, avec lequel on travaille beaucoup en collaboration, qui m'a sollicité pour avoir mon avis. Et c'est comme ça qu'il nous a demandé ce qu'on pouvait faire chirurgicalement. Le but, c'était de penser un peu aux imprévus, d'anticiper toujours le plan B, le plan C, le plan D. C'est déjà assez exceptionnel qu'il ait réussi à marcher dans cette situation anatomique. La structure osseuse était déjà hautement perturbée puisqu'on lui a retiré la moitié du bassin quasiment. Donc il fallait faire avec pour faire tenir la prothèse dedans, peut-être utiliser de la greffe osseuse pour avoir suffisamment d'assises pour faire tenir la prothèse. Et il fallait en plus de ça que les muscles qui lui restaient soient suffisants pour faire fonctionner et marcher que sur un pied. Et son anatomie, elle est unique. On ne pouvait pas tellement se baser sur l'anatomie d'autres arthroses de hanche, d'autres prothèses de hanche. Alors que normalement, on part du bassin dans la direction de la cuisse. Là, on est passé entre les muscles, on a essayé de retrouver, mais sans avoir le chemin clairement établi. Et il fallait absolument lui préserver la continuité fessière sur le côté pour qu'il puisse être stable et qu'il puisse poser le pied après. Ensuite, il y a tout l'aspect séquelles de chirurgie et de radiothérapie. On n'aime jamais trop aller dans un lieu qui a déjà été opéré parce qu'il y a de la fibrose, les repères anatomiques ne sont pas les mêmes, la vascularisation n'est pas la même. La radiothérapie a pour effet d'altérer les capacités de renouvellement de la peau, donc la cicatrisation, et d'altérer les capacités de renouvellement de l'os, et donc la consolidation, la cicatrisation de la prothèse. Donc la radiothérapie, plus la nécessité de lui faire potentiellement une greffe osseuse, ça faisait assez peur. Et on a réussi finalement à ne pas avoir recours à une greffe trop importante, et on a réussi à avoir une tenue sur les peu de centimètres de bassin qui lui restaient. Et on avait d'abord envisagé de redonner un bassin continu, parce que normalement le bassin c'est une sorte d'anneau continu, et chez lui il avait un anneau discontinu qui s'est un peu tordu. Et on s'était dit que essayer de s'engager sur une prise, une greffe qui allait avoir du mal à consolider, ça paraissait trop risqué. Et sur le post-opératoire, vu qu'on avait pris beaucoup de risques, on voulait être prudent. Donc c'est pour ça qu'on a imposé le repos pendant 1 mois et demi, 2 mois, pour que se fasse une fibrose qui stabilise la prothèse.
Donc on a proposé à Julien cette prise en charge chirurgicale en lien avec la clinique de rééducation de Goussonville, dans l'objectif en fait que pendant sa rééducation, il puisse bénéficier d'une rééducation sportive spécifique avec son entraîneur de l'équipe de France, Frédéric Cupillard. Donc ça permettait d'allier un résultat chirurgical pour la marche au quotidien, mais aussi de travailler sur le geste sportif.
La première phase du protocole post-opératoire a été de rester alité 45 jours pour que tout se consolide parfaitement. J'ai passé les 15 premiers jours à l'hôpital de Garches et ensuite je suis allé à la clinique de Goussonville jusqu'au 3 novembre pour continuer ma convalescence.
Je suis docteur Nasser Yahya, je suis spécialiste en médecine physique et réadaptation et médecin du sport. Je travaille actuellement à la clinique de Goussonville. Donc après l'intervention, toute l'équipe a été motivée pour la réussite du projet thérapeutique de Julien. Dès le début, les défis étaient multiples, notamment par rapport à l'intervention lorsqu'il était jeune. Maintenant, le défi par rapport à la réussite de cette mise en place de prothèses compliquées avec une récupération satisfaisante. Maintenant, le troisième défi, c'est reprendre son sport de haut niveau et améliorer ses performances grâce à cette chirurgie et grâce à la force musculaire et les capacités qu'il va acquérir suite à cette intervention.
Donc le 3 novembre, j'ai eu un rendez-vous avec le chirurgien qui m'a opéré, qui a donné son accord pour que je commence à me lever et à commencer à prendre appui. Donc à partir de cette date-là, la rééducation a pu réellement commencer. Ma première impression, c'est que déjà, les douleurs que j'avais à la hanche gauche ont complètement disparu. J'en suis à 2 semaines réellement de rééducation. Les premiers pas donc, se sont faits en déambulateur. Quelques jours après, j'ai commencé à marcher avec 2 béquilles. Et la semaine suivante, j'ai marché avec une seule béquille. Donc, au bout de 2 semaines de rééducation, les exercices qu'on me demande de faire tournent autour donc, de la marche, du vélo et également de la rééducation en piscine. On a un cadre extérieur très verdoyant, on a beaucoup de nature autour, c'est très silencieux, il y a un tas de promenades qu'on peut faire à l'extérieur. Donc ça aussi, ça joue dans le moral et dans la convalescence qu'on a ici au centre de Mousson. Quelles sont les prochaines étapes? Je continue ma rééducation à la clinique de Moussonville. Donc on ajoute tous les jours de nouveaux exercices en fonction de l'évolution qu'on voit avec le kiné, avec les docteurs. Et donc la prochaine étape concrète, c'est que dans 1 mois et demi, je revois le chirurgien pour faire un nouveau rendez-vous de bilan.
So this is at the SPC at Garches. That's finished.